Thank you, Dr. Samyukta. I should thank Dr. Divya and KSOS also for giving me this opportunity. My topic is surgeries on the inferior oblique muscle. Inferior oblique muscle is very unique in anatomy, function, response to surgery, and appearance. So, when we check the history of the inferior oblique surgery, we know it was first proposed by Duane in 1906 as a transcutaneous stenotomy. Later, Dunnington in 1929 suggested this insertion. White was the first to introduce recession in 1943, and Park introduced various weakening procedures. Coming to the indications of inferior oblique surgery, V pattern strabismus with inferior oblique overaction, primary inferior oblique overaction, as you see in infantile esotropia, exotropia, and even in accommodative esotropia, dissociated vertical deviation, superior oblique palsy, cyclotorsion, nystagmus with a head tilt, and rare indications include Duane's retraction syndrome with innervational upshoots, sensory hypertropia, lost or severed or aplasia of the inferior rectus, contralateral eye of superior rectus palsy or MAD. And contraindications include V pattern without an inferior oblique overaction, X pattern in case of a long-standing exotropia, apparent overaction craniofacial syndromes, and in some post-RD surgery when there is an in-cyclotorsion as well as an inferior oblique overaction. Coming to the surgical procedures, the various inferior oblique weakening procedures include myotomy, myectomy, denervation and extirpation, recessions, anterior transpositioning, anterior nasal transpositioning, nasal myectomy, and inferior oblique Y splitting. The commonly done procedures are myectomy, recessions, and anterior transpositioning, and the inferior oblique Y splitting and nasal myectomy are certain new procedures. Coming to the isolation of the muscle, you take an inferotemporal incision 8 mm from the limbus, and perpendicular incisions are made at the tendons to expose the bare sclera. This is a video showing you taking the inferotemporal incision. The conjunctiva is split, and you visualize, you can now see the inferior oblique muscle that is lying transversely, and you hook the muscle under direct visualization. The surgical anatomy, the muscle is 9 mm wide, inclined posterolaterally. The maximum recession that you can do is 12 mm. When you are doing a procedure in inferior oblique, you should take care of the surrounding structures like vortex vein, macula is close to the insertion, and orbital fat so that you avoid the complications. Before cutting the muscle, always make sure that you hook the lateral rectus as well as the inferior rectus. This is an old video which I had from my fellowship time. This is done by, this is a procedure, myotomy actually done by TSS sir. You can see he has hooked the muscle and he has clamped. And cut the muscle, you cauterize it and leave it alone. When you take 8 to 10 mm of the muscle and then you clamp on either side, you cut the muscle, then it becomes a myectomy. What is the advantages of myectomy? It is easy to perform, less time consuming, and complications are also less. And disadvantage is it is irreversible. If you want to do any resurgery on that, it will be going and attaching somewhere on the sclera. You won't be able to pinpoint out where it has attached, and the resurgeries is not possible, and the results are unpredictable. Coming to the inferior oblique recession, you hook the muscle like you have told before, and you clamp the muscle close to the insertion. And you cut the muscle from the insertion. After cutting and securing it in a clamp, you take the sutures. 2 double arm sutures are taken with a 6-0 vicryl on either side, and you secure the muscle. Now the inferior rectus is hooked, and you mark the inferior 3 mm behind and 2 mm lateral to the lateral border of the inferior rectus. The muscle is secured in position After securing the muscle in position, you tighten the knot and you can close the conjunctiva with interrupted sutures or with continuous suture. Now the finger recession is 8 mm recession where the muscle is placed 6 mm inferior and posterior to lateral rectus, and the Park recession that you do for moderate inferior oblique overaction is 10 mm recession, as we have seen now 3 mm posterior and 2 mm lateral to the inferior rectus. Now with anteropositioning, muscle is bunched up and placed adjacent to the lateral end of inferior rectus. It is indicated in case of DVD and unilateral SO palsy with a hypertrophy. This is a child with inferior oblique overaction, large V pattern along with a DVD, and we had done an inferior oblique anterization in this patient. But the problem is it can cause anti-elevation syndrome, as Dr. Samyukta has already told. The neuromuscular bundle of the inferior oblique that inserts the posterior prevent it from elevating. For minimizing the anti-elevation, you can place 1 to 2 mm posterior to the lateral border of inferior rectus. The modified Elliott and Ankin recession is almost anterior end will be the same. The only difference is the posterior end will be inserted 5 mm posterior along the lateral border, so that the anti-elevation effect will be reduced and it has less anteropositioning effect. In anterior nasal transposition, the new insertion will be 2 mm nasal and posterior to the nasal border of the inferior rectus. In this case, the inferior oblique will be transferred from an extorter to an intorter as well as a depressor. So the new insertion will be nasal to the inferior rectus. Anterior nasal transposition is indicated in bilateral fourth nerve palsy and over elevation with severe cyclotorsion as in cranial dysostosis. Advantage is that it avoids the anti-elevation syndrome. Then now nasal myectomy. In case of residual inferior oblique overaction after anterization, the nasal part of the inferior oblique is cut, and the Y splitting is you split the inferior oblique and the posterior part of the Y end is placed posteriorly so that it will prevent the anti-elevation. This also has been described recently. These are the various graded recessions that you can from behind as it reaches the anterior part of the inferior rectus, the weakening effect will be more. Now inferior oblique advancement, usually the inferior oblique strengthening procedures are rarely mentioned and done. Inferior oblique advancement has been studied by Goldstein, and it is indicated in A pattern esotropia, where you disinsert the inferior oblique, pass it under the lateral rectus and attaches to sclera 2 to 3 mm superior to the lateral rectus and 8 mm posteriorly. Coming to the complications of the inferior oblique surgeries, hemorrhage. If you disrupt the vortex vein, there will be massive hemorrhage and retrobulbar hemorrhage and all. Persistent pupillary dilatation, transient pupillary dilatation because your nerve to inferior oblique has been damaged, injury to the lateral rectus, macular trauma if you are inserting and taking bite by accidental injury, undercorrection, anti-elevation and fat utterance. Visualize and proceed in case when you are doing an inferior oblique surgery. Isolate the entire muscle. If the muscle is not fully hooked, it can result in undercorrection. Avoid the vortex vein to prevent hemorrhage, and dissect closed muscle to avoid fat utterance, and avoid disrupting the orbital fat complex so that the fat utterance will be prevented. And keep new insertion behind the inferior rectus with posterior fibers posteriorly so that anti-elevation can be prevented. Thank you.
Thank you, Resmi madam.